be here. So having somebody proctor the exam for you, and then in the afternoon for lab, one of the guys that helps me in the PT anatomy lab will be here. His name is Rick Hendricks. He's a physical therapist, but I think he practices a little bit, but pretty much he's just does affiliate faculty stuff for us and helps in anatomy and a bunch of other things. So he's very good at the anatomy, so he'll be able to help you, and if you need help dissecting, he can do that, those kinds of things, okay? Tomorrow I have a faculty, an interview for a faculty position coming in at 4 o'clock. So if we can meet earlier, like 3 o'clock or something like that in the lab to kind of work on some stuff, that would be great. If not, then I can meet you after that's done, so probably closer to 5. But I know you guys have class at 6, so or you can do it either way, or both, doesn't really matter. So I think those are all the announcements. Okay. Do you guys have any questions? You guys are so quiet. Why are you so quiet? The Broncos won. Okay, so anyway, did you guys get access to the questions and the answers and everything? What's the answers? I changed the switches on it, so they should be out. I saw 22 attempts, so I thought that was a good thing. But I thought I changed this. I thought what I found out was I put kind of sub restrictions on it, and somehow one of those sub restrictions said you couldn't have access to them. But I think I changed all that. So, but did you guys have any questions about that style of question? About that depth of question? Yeah.
Like C5, C6, whatever, like those kind of things with each level. Is that, do you want us to know?
Well, you know what, so that question on there is really more kind of the organization, the brachial plexus, and not the individual piece to another. I think for at least this exam, I'm going to stick to the name of the nerve, okay, and not get bogged down in the particular segments of innervation to a muscle. Now, specific to that, I do want you to know the dermatomes. You know, the easiest place, from a point of view, you really just need to know hand, so C6, C7, C8 kind of deal. But not to get bogged down so much in, what are the segments of innervation to flexor carpi ulnaris? You know, is it C7, C8, T1, or is it C8, T1? You know, just because that C7 is somewhat of a variable contribution. So if we just stay to the innervation root, flexor carpi ulnaris is the ulnar nerve, to the lateral 2 digits, to flexor digitorum profundus is the ulnar nerve. Everything else in the forearm is the median nerve. Don't get bogged down in the anterior interosseous nerve specific to quadratus, pronator quadratus, okay? Just median nerve, okay? When you get to thenar eminence versus hypothenar eminence, median nerve versus ulnar nerve, okay? From the extensor side, I think it's important to understand the difference between radial versus deep radial versus posterior interosseous because of the way that particular nerve travels through muscles, you can actually divide out clinically when that nerve gets compromised. So when you think about, if we were to trace out that radial nerve, And so as it's coming, so the radial nerve as it's coming down, when it crosses lateral epicondyle, when it crosses that, it then, the way it's described is it's going to innervate two muscles. And then it's going to continue and divide into the deep radial that innervates two muscles, and the other division is superficial radial, and then let me do this way a little bit. And then as it innervates those two muscles and then continues on down, then it's changes its name. So up here, so up here, as it comes through and out of the triceps to then lie deep to brachioradialis, it goes through a connective tissue tunnel, and it can be impinged. And if it's impinged at that level, then everything distal to that may have a motor change, weakened motor activity, and in addition to that, it's going to have a sensory component to it because it's losing this piece. If we label these, then this is the radial nerve, these two are radial nerve, these two are the deep radial nerve, and then this last arcade that it goes through is coming out of the supinator next to the bone, and then becomes the posterior interosseous nerve. And then this dashed line over here is superficial radial. And this is only cutaneous. Okay? So when you look at those things, you say, okay, what is it that we can look at in terms of these connective tissue tunnels or muscular tunnels that this nerve goes through, and we even go more proximally and look at it as it's lying on the bone in that triangular interval where we see it on the back side of the humerus, is that those are areas where, say commonly, but certainly areas that have been shown to have a point where that nerve is more likely to be restricted in its ability to transmit action potentials, either motor signals down to the muscles or sensory signals coming back to the spinal cord, okay? So up here you have the impingement up here is on the humerus. Here it's on the lateral epicondyle and triceps, and then here it's through the supinator. Okay? When you look at those areas, the fact that those muscles, because they have that gap in them, but still attached to the bone, that means if that muscle is tight or is inflamed, or the connective tissue attachment around that is inflamed, then that nerve can actually be compromised. And in doing that, we get weakened extension. Okay? So here, we're going to get primarily just weakened extension of the fingers. Because the extent, let's say it's here. What would be the result of weakened extension beyond the fingers in terms of asking a patient to extend at the wrist? So when I ask that question, you have to say to yourself, okay, what muscles are innervated from here down, and what muscles up here still have a intact muscular signal? Okay, and so if you think about that, you say, okay, what are these two muscles up here that are innervated by the radial nerve? Not a rhetorical question. So what muscles are innervated by the radial nerve as it's coming around the lateral epicondyle? Brachioradialis, and okay, extensor carpi radialis longus. So then, as it hits those two muscles, then the remainder of that then divides into a deep and a superficial branch. Okay? So now, what muscles are innervated by the deep radial branch? Pardon? Okay, so we have ECRB and supinator. Okay? Which means, what? In terms of if we compromise the remainder of that nerve as it goes through the supinator, so we can extend at the wrist, but what's that extension going to do? Is it going to be a nice, complete extension, or is it going to deviate one way or the other? It's going to deviate to the radial side. Why? Because we've lost the innervation to extensor carpi ulnaris, or at least we've compromised it. You know, whether it's weakened or whether it's absent, that's, not necessarily a big point, but the fact is, after these four muscles that are the muscles you identify on that posterior compartment of the forearm, everything else is innervated by branches of that posterior interosseous nerve. So that's extensor carpi ulnaris, the extensors for the index finger, for the little finger, the common extensor muscle for all the digits, as well as the muscles that are innervating abduction and extension of the thumb. All of those muscles are at risk of being compromised or losing some sort of function, whether it's weakened function or absence of function. Okay? So then if we think about that, if you're compromising it up here at the humerus, in that triangular interval, we basically have lost everything from the elbow down. We usually don't see that we've lost extension at the elbow level. Why is that the case? So remember, radial nerve in one is the innervation to all the triceps, all points of the triceps, the heads of the triceps, the anteriors, all of that. So why is it that you would suspect that you would still have the ability to forcefully extend at the elbow but have lost everything in the forearm if you compressed the radial nerve out here or here? Why would you suspect that you would still have extension at the elbow? If there's extension at the elbow, which means the triceps are firing, are they innervated? Or are they going to get an innervation from somebody else? So think about this. Let's take this scenario again. So this is a branch of the radial nerve, but if it's compromised here, we only get a certain component of that musculature that's being innervated by branches of the radial nerve. We only compromise some of them. Why? Because if it's here, all of these are intact. Does that make sense? So if we pinch the radial nerve as it's coming around the humerus, and we still have extension to the elbow, what's happened? We've left the innervation to the triceps intact. In other words, those branches of that radial nerve have already left that nerve as it's wrapping around the humerus and have already innervated the tricep muscle. So now we can go ahead and extend at the elbow. We just can't extend at the wrist or the fingers or the thumb because the branches have left the building up here. Okay? So that's the kind of things that you think about muscular activity, and you think about the innervation to those muscles. And you say, okay, what does that mean? Well, it means I memorize the table. But that's not what you guys need clinically. You guys need to think about it from the point of view, okay, I have somebody that's had injury. Just call it an injury, forget what it is, or the mechanism of that. But they've had an injury that's compromised the posterior cord. Okay, remember that the posterior cord is giving rise to two primary nerves. That's the axillary nerve and the radial nerve. So now if you think about it from that point of view, if you just think about that posterior cord and you look at the functions that all of the nerves subserve for that particular nerve, if the posterior cord is damaged, we lose both axillary nerve and radial nerve. In other words, when you look at the functions of the muscles that those two nerves innervate, we lose the axillary nerve, we lose force or strength in terms of abduction at the glenohumeral joint, as well as probably losses of a certain amount of force in terms of extension at that glenohumeral joint, flexion at that glenohumeral joint, internal, more external rotation than internal rotation because we've got a lot of strong internal rotators. But you think about loss of that and the ability to raise our hand up, our arm up over our head, is we're not going to get that glenohumeral, we're not going to get that arm, that upper extremity, even to 90 degrees. Okay, it's never going to go above probably 45 degrees. So even if we can then rotate our scapula, then we're only going to get our arm up here. Okay? And in addition to that, if we've lost the posterior cord, we've lost the radial nerve too, which means we're not going to have extension at the elbow, we're not going to have extension at the wrist, we're not going to have extension of the fingers, we're not going to have extension of the thumb, and we're not going to really have very much abduction of the thumb as well. Okay? So that's why I think at this point, until I know something different in terms of where you guys need to be, I want to stick at the names of the nerves and the muscles that are being innervated. Okay? So if we then, I think it's important for you to know the makeup of the brachial plexus, how it gets to the names of the nerves and the segments that are potential in that nerve. Okay? I want to to stress potential. Okay, because we can't really look at that much more than that and make a prediction to say, okay, if we look at the radial nerve, potentially, what are all the segments that are available to the radial nerve? Remember, it's coming off the posterior cord. Posterior cord is a combination of all the posterior divisions of the three trunks. The three trunks are combinations of the 5 roots. So potentially the radial nerve has what? C5 through T1. Now certainly C5 doesn't play a huge role in the radial nerve, plays a huge role in the axillary nerve, but we could also make that argument that the axillary nerve potentially has what segments? C5 through T1, because it's a direct branch of that posterior cord. Then it gets to the point we know that's not the case, but that's not what I want you guys to think about right now. Okay? I want you to know what the brachial plexus is from the point of view of putting it together and understanding the branching patterns specific to roots, to trunks, to divisions, to cords, to the terminal ends. Okay? And don't get too bogged down right now in that. If we have to come back and come up with a plan of how to kind of add that piece back into it, then I'll figure that piece out, okay? But right now, if you know that the supraspinatus and infraspinatus muscles are innervated by what nerve? Suprascapular nerve. You know, sure, it's a branch of the superior trunk, and the superior trunk, therefore, should have only C5 and C6 in it. That should tell you what the innervation is. But if you can just remember suprascapular from the superior trunk and that it innervates 2 muscles, that's great. Okay? And the reason behind that is I want you guys to think about walking through this exact scenario. Okay? How do you know when you're doing an exam on your patients, what are your tools that you have to use to think about that? Are there weakened muscles? Are there areas of the skin where there is some sort of paresthesia? It might not be a total anesthesia or numbness, but it could be a paresthesia. It doesn't feel the same to them. You stick them with a pen and it feels sharper than they think it should. That's kind of a paresthesia. The axons carrying that information from those receptors is bringing information into the central nervous system, but because there's something that's wrong with the axon, it's impinged, or it's stretched, or it's something, then we get a sensation that's not what we think is normal. Okay? So that's what I want you to think about. So if I said to you, if there's an impingement of the ulnar nerve as it wraps around the posterior part of the medial epicondyle of the humerus, where are we going to experience sensory changes in the upper extremity due to that impingement? You know, I'm going to say it's numb or paresthetic or whatever, but where are we going to see sensory changes? Okay, so you're pointing to kind of there. It's more specific.
So numbness in your fingers, or even.
What's the innervation of this part of the skin? So medial cutaneous nerve of the forearm. So if you're impinging here, medial cutaneous nerve is not there. So this part of the skin is probably intact. This is not. Now, if it's normal distribution, is this entire finger involved? Yes. Is this entire finger involved? No. It's only half of it. It's only half of it, because the median nerve comes over and does 3.5, including your thumb counting 1, 3.5 fingers, split right down the middle in normal distribution. And then normal distribution for the median nerve doesn't just do the palmar side, but comes over, and we can just say kind of halfway through the dorsal side of the digits to half of this digit. What's the rest of this? No, I'm not talking dermatomes. I'm talking name of the nerve. What part of the radius? Superficial radius. Okay? So superficial radial nerve is only cutaneous. If I say that, we can equate that to, does it bother me if I keep talking about it? What do you have to turn? So superficial radial is only cutaneous, which means it's bringing sensory information back to the spinal cord. Do these northern branches have sensation in them? What sensation do they contain?
Proprioception?
Absolutely, proprioception. So muscle spindle inflammation, Golgi tendon inflammation, things that are receptors that are used. I'm hoping that this is a review from last semester. That those nerves are still mixed nerves. I won't do that yet. Are still mixed nerves. As is, this is a mixed nerve. Although we don't think of it, we think of it as totally sensory, but it has autonomic components to it. It has autonomic motor pieces to it that are going to drive capillary bed perfusion. So all of these are mixed nerves. But when we were talking about the somatosensory system, we talked about this as being sensory, these being motor. But I don't want you to discount the fact that they're motor, but they're not sensory nerves. Because the sensory side of this is equally as important as the motor side. What's the piece that you're going to notice in a reflex arc if you lose both the sensory and motor side of that reflex arc? You're not going to see any motor response. So you can, whether the sensory receptor is intact and the afferent limb is intact, if the efferent limb is gone, no matter what you do to it, that muscle isn't going to do a thing. Okay? But keep in mind, these are motor and sensory, and these are motor and sensory. For you guys, testing it is when you look at muscle stretch reflexes, what's that going to give you? If you have a muscle stretch reflex and it's exaggerated, what does that mean to the reflex arc? Is it intact or not intact? If we tap brachioradialis and we get a rapid response as opposed to a small jerk, does that tell us tells us what? It's intact. It just tells us that something inside the central nervous system isn't functioning correctly. But the peripheral side of that is intact, which means that radial nerve is intact, both sensory and motor side of it. Okay? So, what I want you guys to think about is as we go forward, what does it mean to know the name of the nerve, the muscles it's innervating, those kinds of things, because they become your diagnostic tool. And then they become your target for some sort of intervention. Okay? So if we think about the radial nerve, and I'm not just going to stay on the radial nerve, we'll get to medial and ulnar nerve too. But when you think about that from the point of view of radial nerve integrity, you look at it and say, okay, from that posterior cord of the radial nerve, and as it descends through the entire posterior component of the upper extremity, in other words, posterior part of the arm, triceps muscles, heads, cross the elbow to the posterior part of the forearm, extensor muscles at the wrist and the fingers, that along that line, you should be able to look at that and use kind of the pattern of innervation and the branching pattern as to what's going to happen if it's compromised. Inclusive of the fact that there's a very obvious cutaneous innervation to the posterior part of the hand for 3.5 fingers up to kind of mid-digit, okay? Okay, so using that logic, if we damage the ulnar nerve at the medial epicondyle, what are we going to see in terms of flexion of the wrist? If we ask that patient to flex the wrist, what's going to happen to the wrist during flexion? No, don't go there yet. I'm just talking wrist. So if we lose, what do we lose? If we damage ulnar nerve coming around the medial epicondyle, what do we lose in terms of motor innervation to the forearm? We lose innervation to what are the two muscles? Flexor carpio-ulnaris and these two deep long flexors. Flexor digitorum profundus, just to these two fingers, 4 and 5. There's the early innervation within the forearm of the ulnar nerve, which means the remainder of the ulnar nerve, motor side, does what?
Cutaneous?
The motor side. It does cutaneous, but the motor side. Why do we call, how do we get a common name for the deep branch of the ulnar nerve? Its common name is the innervation of the intrinsic muscles of the hand. So it's going to innervate the lumbricals for these two fingers. It's going to innervate all the interosseous muscles, both palmar and dorsal. And depending on the textbook, it's going to be the entire innervation to adductor pollicis. In other words, pulling the thumb back down. So it does all adduction of our fingers. It pulls our thumb back down, and it assists in this positioning of these two fingers. That's why we call it the innervation to the intrinsic muscles of the hand. Which means the median nerve is left to do everything else, which is what? Femur muscles. I forgot the hypofemur muscles for that. Femur muscles, as well as lumbricals for these two muscles. And some books, depending on how they want to couch it, some books are going to say the median nerve is also going to innervate parts of adductor pollicis. Okay? We're going to find a couple places where there's the potential that muscles get innervated by two separate nerves. And adductor pollicis in our hand is one of those nerves or one of those muscles that sometimes gets listed as having dual innervation, sometimes only one. So, doesn't really matter. Ultimately, We lose hypofemoral muscles, we lose abduction, adduction of all our digits except for our thumb, and we lose these two lumbicals. Okay? Which means if these two are, if all those little muscles are paralyzed by this, what are we going to get? If these muscles are all paralyzed, including these little muscles, we're not going to be able to do this. We're going to end up with some extension of these two fingers because there's no tone to the long flexors on this side. So we get a little bit of extension. Okay? Why? Because there's tone in those muscles versus no tone. Okay? So you guys talked about tone last semester? What is tone in the muscle? It's kind of that resting, cross-bridging of muscle fibers. Okay? And we can change that by decreasing the firing or increasing the firing, and ultimately come up with either relaxed muscles or contracted muscles. Okay? So, if you think about that, then we lose the ability when we've lost our ulnar nerve, or we've compromised it, and the biggest part of compromising that is, that we usually see is we bang our funny bone, okay? Which is really just hitting that nerve because it's very, very superficial, okay? Can you tell the difference between the involvement of the ulnar nerve at the level of the medial epicondyle versus something up in the axilla? So if I stretched just the ulnar nerve, I'll go to that in a minute, just the ulnar nerve up there versus having it compressed here, are we going to see a clinical difference in those two scenarios? We say yes. What is that difference?
Well, it's gonna, you're not like, you're not flexing it, so it's all straight. It's all left.
So if I stretch it here, am I going to be able to flex the elbow forcefully? Sure, that's musculocutaneous nerve. What about, am I going to be able to forcefully pronate the forearm if I damage the ulnar nerve up here? No. Because what is the primary or the forceful pronator for that forearm position? It's pronator teres. Pronator quadratus will do it, but it's a little muscle and it doesn't have the same force that pronator teres does. Okay? So while it's not going to affect flexion at all at the elbow, because even though these guys can work as flexors, if you're in the anatomical position, brachialis and brachioradialis and biceps brachii are all going to be forcefully flexing it. So to lose any sort of support of flexion of these muscles isn't really going to do much. Okay, so you're not going to see much in terms of a diminished flexor capability at the elbow. Certainly at the wrist, you would, because we've lost flexor carpial nerves. If we damage this here, then we have started to lose that innervation to those four superficial muscles. So flexor pronator teres, flexor carpi radialis, palmaris longus, and flexor carpial nerves. Okay? So we're going to lose some of those muscles. What happens if we lose the median nerve? Are we going to lose flexion at the elbow? That's the other innervation to these flexor muscles. These muscles coming off of this medial epicondyle. Are we going to lose flexion at the elbow if we lose median nerve? No, because again, its musculocutaneous nerve is the primary muscle for forceful flexion of the elbow and radial nerve. Because we have biceps brachii, brachialis, brachioradialis. These muscles over here, whether they're innervated by the median nerve or the ulnar nerve, aren't going to do anything. They're minor compared to the other muscles. Okay? When you guys look at these muscles and you look at the size of them, and you look at kind of their tendinous attachments or their tendinous arrangements, just look at them and think, that's not as big a muscle as that. And that tells you where the strength of those particular actions are. Okay? So now let's take a step back and go back to the brachial plexus. If we lose the medial cord of the brachial plexus versus the ulnar nerve, have we lost anything different in terms of musculature in the upper extremity? So again, just muscle. Don't think anything other than that. Is the difference between the ulnar nerve and the medial cord have any difference in terms of muscular innervation of the upper extremity? No. So medial cord, ulnar nerve, same thing. But if we have medial cord involvement versus ulnar nerve involvement, what have we added into that clinical examination that we might see? No, medial cord. So don't go to the contribution. You're right, in essence, but that's not where I was going. What is the other component of that medial cord that would be added into that clinical scenario? We already have that ulnar piece. What's the other piece? Medial cutaneous nerves of the arm and forearm. So if we get medial cord, the potential to also involve those branches that are innervating the skin on this medial side of the arm and forearm would be brought into play. So now we have numbness here, as well as the weakness of flexion at the wrist and weakness of the intrinsic muscles of the hand. So at that point we can say, okay, that involvement is here, not here. Because if it's here, those cutaneous nerves have already left the medial cord and are already out in the skin. Okay? So now let's go to the other side of that and go back to where you guys wanted to go, which is that medial root to the medial nerve. Okay? So now we have the medial root to the medial nerve. What does that add to the medial nerve in terms of segments? That's just segments. We're not talking muscles now. What is it that medial root of the medial cord adds to the medial nerve? C8 and T1, exactly. Okay? Now, if we think about that, and again, this is not really, this gets to the segments in terms of hand musculature, but if we lose C8 and T1, contribution to the median nerve, we actually are going to lose intrinsic muscles of the hand specific to the median nerve. Because everything in the hand, in terms of intrinsic musculature, whether it's on the flexor side or the extensor side toward the thumb, are all C8 and T1. Okay, I'm not going to ask you that question, but just so you know that when you look at that, the innervation to all the little muscles in the hand that are driving fine motor activity are coming from C8 and T1. Whether they're coming through the median nerve or they're coming through the median nerve. Okay? Or they're coming through the radial nerve, posterior osseous nerve for extension of the thumb. Okay? Everything's C8, T1. But if we think about that, say, okay, we've got that point, so now we've lost that contribution. Now it does, to some extent, come to the point of saying, now that's kind of where segments play a role. Okay, that's where, if we went to that level, we would say segments play a role. If we lose C8, T1, or we lose that medial root to the median nerve, then everything that's going through the median nerve now is just from the lateral cord, so C5, 6, and 7. Okay? By and large, that's going to get us keep intact most of the long flexors of the fingers, these two fingers. It's going to give us pretty good innervation to pronator teres, flexor carpi radialis, and palmaris longus if we have it, flexor digitorum superficialis. So we still have a large complement of innervation to those muscles. So it really wouldn't seem much in terms of change in motor activity if we lost the medial cord more superior or more proximal before that medial branch of the median nerve comes off. Okay? So it's the big piece in terms of that diagnosis is to look at it from the point of view of ulnar nerve involvement, where along the line that has come about, as well as is it proximal enough to also get the innervation to the skin on the medial side of the arm and the forearm. Okay? Okay, so are we okay kind of on that idea of kind of our distal musculature and the 5 main branches? Are we really? Honestly? Okay. Honestly, or are you just saying, sure, Cliff, go on? Because the whole idea of this, learning anatomy, I had to learn anatomy because I was in the anatomy department. So I had to learn it. You guys have to learn it because it's your tool. And you need to be able to think about it from that point of view. How are you going to use that tool? If you were a carpenter and I gave you a hammer and you tried to screw a screw in with your hammer, although I've been known to just hit the devil out of a screw trying to use it as a nail, but that's not its proper use. So your tool is to know that anatomy to the point of view that you can actually use it as 2 things. One is it's part of your examination. What's intact, what isn't intact, what's hardly intact, and maybe those muscles are weaker than they should be. And then, what are you going to do with it? Depending upon what it is, do we rely on those muscles that still receive partial innervation to try to make them stronger and compensate for weakness? Do we try to, did you guys talk about neuroplasticity last semester? Do we try to enhance the activity of those nerves that might be compromised to get them to kind of wake up and do their thing better? But what do you need to know for both of those? You need to know the nerves and the muscles. Okay? So, if we think about that, and we've got kind of covered sort of, briefly and superficially, the distal parts of the upper extremity. One piece we haven't covered is how that axioscapular or axioappendicular or scapulothoracic group of muscles are activated, what they do in concert or synergistically to position that upper extremity so it can do its thing. So if we look at muscles that are designed to anchor and stabilize the scapula to the thoracic cage, we're not talking positioning of anything, what muscles are doing that directly? And before we go there, what do they have to be that kind of muscle? They have to have two different attachments, one in one place, one in the other place. And what are those? They have to attach to the spine or to the thorax. And they have to attach to what? To the scapula. Anything else is a muscle that can assist in that, but they're not really scapulothoracic muscles. And what's the one muscle that can assist in that but is not a scapulothoracic muscle? It's attached to the thorax, but it's not attached to the scapula. Latissimus dorsi. Okay? Because it's attached to the humerus. But it can function that way if we anchor that renohumeral joint down. It can help to anchor that scapula or that complex, the shoulder complex, to the trunk. Okay? But what are the muscles that do allow us to stabilize the scapula to the trunk? Trapezius, serratus anterior, pardon? Rhomboids, pardon? Nope. Why not? Because it's attached to the scapula to the humerus. Okay? Levator scapula. Is that dropped already? Pec minor. Try the anterior tilt by shoulder. So pec minor. So those muscles, the rhomboids, the trap, levator, serratus anterior, pec minor, all have an attachment on the thoracic cage, or the thoracic unit, the trunk. Trapezius, rhomboids, levator, scapula all have attachments off of, in some part, the spine. Spinous processes of, everywhere from the base of the skull all the way down to mid-thoracic level. The other two muscles, serratus anterior and pectoralis minor, come off the ribs and attach to the scapula. So that set of muscles, now again, here's that open chain activity. In that open chain activity, those muscles are designed to move the scapula in relationship to the thoracic cage, or to the trunk. If in any sort of instance they co-contract, they're ultimately going to result in the fixation of that scapula to that thoracic, to that posterior lateral part of the thorax. In other words, really over the ribs, because even completely retracted, the medial border or spinal border of the scapula is not touching the spinous processes. It's still on the back of the ribs. Okay? So you have a series of muscles, that are designed to do two things. One is to fix that bone to the thoracic cavity or thoracic cage. And then the other side of that is to move that and position it so that it can ultimately allow for a positioning of the upper extremity to do something functional. If it was just anchored at the back, like the skeletons in the lab with a pin through a rib, all they're going to be able to do at that point is to rotate. Because you just have one pivot point in it, and it's just going to rotate. It's going to upward or downward rotate. That's all it's going to do. It can't protract, retract, can't elevate, depress, and it can't tilt. Okay? But none of them act in isolation. Even just raising our hand over our head. So when you think about raising our hand over our head, what muscles allow for that upward rotation, superior rotation, or upward movement of the glenoid fossa? What parts of the trap? Upper fibers and, no, not the middle, lower fibers. Okay? What else does that? No? Deltoid does that, but it has nothing to do with scapular movement. Just scapulothoracic muscles. What muscles give us upward rotation? Upper lower fibers of the trap plus what? Lat doesn't do it. Remember, lat is trunk. Rhomboid's going to downward rotate. Okay, let's think about this. So that was I heard it. Let's do this somewhat diagrammatic. Okay? So here are our spinous processes. That's our spine right there. And here we have this nice triangular bone like that, which got a spine. Okay? Now, if we think about this and we say, okay, how are we going to get this point to move upward? And also to think about it as this point moving lateral. Because a lot of times it's explained that way as well as medial and lateral rotation in the scapula. Your books don't do that, but it's another way to think about it. And is if we're going to get this thing to pivot that pushes this up and this out, then we need a pivot point. Okay, so there's our pivot point. It's like that little silver pin in the cadaver, in the skeletons downstairs. Okay? Now, we're thinking about muscles that ultimately want to pull this up and pull this out. So if we have muscle fibers that are out like this, they're going to pull that lateral edge up, pulling on the acromion and actually pulling on the clavicle that's attached to the acromion. Okay? And then you have muscles, fibers that are pulling down like this. And if you notice what's happening is that these fibers are pulling from on the medial side of that pivot point, and these are pulling lateral to that pivot point. Okay? So these are going to pull that up, and this is going to pull this down and just pivoting it around that point. So upper and lower fibers of the trap. If we wanted to say the middle fibers of the trap, I'll put them in dotted lines, they're pulling straight at that pivot point. So all we want to do is retract those. That bone, okay? Now, the other one, which is the harder one to think about, but it's really important, is serratus anterior. And if we have a bunch of ribs out here, I'll draw them like this. And we have coming off of these remember, that muscle's coming up and is attached all along the inner side of that medial border. And look where they're pulling with respect to that pivot point. So they're pulling this medial border down around that pivot point, which is going to pull this lateral, push that up. So the combination of serratus anterior, upper and lower fibers of the trap, give us that scapular upward rotation. Okay? Does that make sense? So now we're able to do that. We can, and forgetting about scapulohumeral rhythm, then those muscles are designed for that upward rotation. Okay? Now, without these guys over here, that muscle's also allowing protraction, pulling the scapula around the side. Okay? What happened, what's the name of the nerve that innervates serratus anterior? The long thoracic nerve, which is coming off of brachial plexus roots. Okay? So damage to that, and really the damage is usually not at the root level, but because that nerve comes down and sweeps out along the rib cage and comes all the way down to innervate serratus anterior, then it's usually stretching of this that pulls that nerve in this area that causes it to kind of get stretched to the point where the action potentials going over that nerve are not getting there or not getting there in the right time, which then makes this weaken, which then doesn't allow this point. Now the thing that's hard to see in this 2 dimensions is how does it fix that medial border? Well, you have to remember, if we look at it from the point of view, if we took a cross section of this, and we have the rib cage, and we have the scapula like this, that muscle is pulling all the way from here. So you think of this vector through the cage, it's trying to pull that medial border in at the same time when it's pulling it around. Okay? And so if you think about it from that point of view, it's critical for fixing that medial border against the thoracic wall. Okay? In isolation, does it do it efficiently? Yeah, okay. What makes it a stronger fixer of that medial border on that posterior thoracic cage? What has to co-contract, or what could co-contract to really fix that medial border? What other muscles are attached along here? The rhomboids. So you have a retractor and a protractor, and they're co-contracting at the same time. We're not going to retract, we're not going to protract. All that combination is going to do is cause this to anchor right there. That fixes it. Okay? So you think about that and you say, okay, that's great. That's how we can use these muscles. What nerve is innervating these rhomboids? Pardon? Somebody said dorsal scapular nerve. What else is it innervating besides the rhomboids? Right, relator scapula. Okay? The branches for that, even though not all of them are from the brachial plexus, where do they come from? Do they come from roots, trunks, divisions, cords, or branches? They come from the roots. Same place that the long thoracic comes from. but coming off the roots of that brachial plexus, okay? And combining differently away from the rest of that combination of the brachial plexus, okay? So if you think about those kinds of questions, so here's my assignment to you guys for between now and tomorrow when we meet in the lab, is I want you to come up with scenarios of how to kind of think about combinations of muscles and combinations of nerve innervations. Okay, again, names of nerves, not segments. Okay? Do you guys have any questions? Keep going. You got a couple more minutes. What's the innervation of trapezius? Spinal accessory nerve. Okay. What muscle results in anterior tilt of the scapula? Pec minor. Pec minor is innervated by what? Medial pectoral nerve. What's lateral pectoral nerve over there? Is medial pectoral nerve also innervated pec major?
Yes.
Is pec major a scapular fixator? What is the difference in attachments between pectoralis major, latissimus dorsi, and teres major? What's the simple way to say that? They all attach to the bicipital groove. But there's several differences. Pec major and lateral. Think about this. How do you remember this? How do you remember that attachment? If you think about the humerus, if we cut a cross section, a transverse section through the humerus, through the bicipital groove. So here's the bicipital groove, here's the humerus, here's the mineral core. So here we have, this is lateral, this is medial. Now you think about how those muscles, how do you see, if you're going from front to deep, how do you see those muscles? If they are layered as they attach to here, so we have one muscle, don't do that yet. We have one muscle, two muscle, three muscles. Okay? So three muscles attached to that same general area. If you're looking at that from anterior to posterior, what's the most anterior muscle you see? It's pectoralis major. Does it make sense that it's going to be the most medial attachment where these other two muscles would have to pass through them somehow to be attached laterally? No. So, pec major to the lateral lip. Okay? Now we have the intertubercular groove and the medial lip, and we have two muscles that are coming from really posteriorly. We have teres major and latissimus dorsi. Okay? Now, when we're looking through the axilla, well, let's do it this way. When we're looking through the axilla, we reflected pec major, and we see this common tendinous attachment coming this direction, into the medial side of that groove, we have to think about the fact that these muscles, as they come from posterior to anterior, is they twist. So when you look at it from the posterior side, you see teres major coming through, and you see latissimus dorsi coming through. If they didn't twist, if they didn't have this twist to this way, so they kind of twisting laterally as they come through, then you would say if they just come through, then the next muscle you would see would be teres major, and it would come into here, and latissimus would be the most posterior muscle and go here. But because those tendons twist as they come forward, what you really have is you have latissimus, you see the latissimus tendon here, and teres major coming to the medial lip. So this is lat, and this is teres major. Okay? So I have three muscles all coming really kind of to the same area. Again, generally to the intertubercular groove or bicipital groove, whichever one you want to call it, I don't care. But ultimately, when we're coming from anterior and posterior, what we really see first, once pec major, is we really see the tendon of latissimus dorsi anterior to teres major tendon. And if you then think about it from the point of view of how is it going to make most sense for them to attach, then you have the lat lying in the depth of the groove, and teres major really being pretty much restricted to the medial neck. Okay? So, if you think about that, kind of put that into a perspective as you look at things, it kind of helps you put the attachments together. Even though, so if we did this, even though we're looking at kind of this sequence of muscles, how are we defining the inferior part of the axilla and the change from axillary to brachial vessels? What's our landmark? Teres major. So even though what you see in the axilla is primarily the lat tendon, we're still defining it as that, anatomically. If you guys see it in the lap, and you see the vessel below that tendon is complex, regardless of whether it's lat or teres major, we've then passed the bottom part of that, or the inferior boundary of those two tendons, so we're in the arm, we're in brachial vessels, okay? So don't get bogged down in, am I looking at lat tendon or am I looking at teres major? If you're below that, you're out of the axilla, okay? What's the relation to teres major? What? Which one? There are three of them. Or there are two plus one that's named something different. So you have upper, middle, and lower subscapular ribs. Middle subscapular is just the thoracodorsal innervation to latissimus dorsi. Subscapularis gets upper and lower subscapular nerve innervation. Teres major gets okay. And again, middle subscapular, if you see it on the list, is just thoracodorsal nerve, but I think your text just calls it thoracodorsal nerve. Okay? Those three nerves come off what cord of the brachial plexus? Posterior. We're looking at posterior cord lying on the subscapularis as it's branching, which is terminating with axillary radial nerves. Okay? So, behind the axillary arteries or axillary vessels. Okay? more questions? Any more questions from you as opposed to from me?
We need to learn about the arteries as well.
Pardon?
The arteries.
Again, the arteries, I told you, I want you to know kind of the major sections of it, and we're not getting bogged down in how the anastomotic circulations are formed. I went through that a little bit, but I just want you to understand it from the point of view of there are many branches that serve that anastomotic circulation around the scapula, around the head of the humerus, and then down around the elbow. I don't want you to have to sit there and say, which branches, what are the branches that make up the scapular anastomosis, what are the branches that make up the humeral anastomosis, those kinds of things. But what I do want you to know, in relationship to those branches, what vessels and nerves, or vessels only, are found in what spaces when we define them from the posterior side of the upper extremity. In other words, triangular space, quadrangular space, triangular intervals, and the boundaries. Okay? Anything else? If you have questions, guys, please don't feel like you can't email me. Okay? If you have questions, email me. I'll answer them. I will, again, tomorrow I'll be in the lab at 3 if you guys are there. If you're not there, then I'll come back at 5. Okay? But I really have to see this faculty candidate, so. All right?
Thank you.
All right, guys.